Welcome to the Funnel Effect.
It is really wonderful to be here today for this. We have a completely monumental topic to cover.
We certainly do. Today, we're not just looking at your run-of-the-mill medical study. We're really examining a pivotal moment in the history of cardiology.
Right.
We're doing a deep dive into a paper that attempted to solve a paradox that had been, well, plaguing doctors for decades. How do you stop a massive heart attack without causing the patient to bleed to death?
It's the ultimate tightrope walk in emergency medicine.
Exactly. So we are doing a deep dive into a paper titled, and bear with me here, Effects of Fondaparinux on Mortality and Reinfarction in Patients with Acute ST Segment Elevation Myocardial Infarction, the OASIS-6 randomized trial.
It is a very dense title.
Yeah.
But the implications are just enormous. And per the requirements of this deep dive, and honestly, just to honor the sheer scale of this work, we have to acknowledge the expensive team behind it.
Absolutely. The authors listed on this massive undertaking are Celine Youssef, Shamir Armita, Susan Krolevicius, Rizwan Afzal, Janice Pogue, Christopher B. Granger, Andre Zubudaj, Ron J.G. Peters, Jean-Pierre Bassand, Lars Wallentin, Campbell Joyner, and Keith A. Fox.
Quite the roster.
Yeah, a huge global team. And this research was published in JAMA, the Journal of the American Medical Association, on April 5, 2006.
That date is really important to keep in mind for you listening. 2006 was a time when the treatment of heart attacks was in a real state of transition. We were essentially moving from the era of sort of educated guessing to an era of absolute precision.
Let's set the stage for that, because the numbers involved here are frankly staggering. To understand why this trial matters to you, to the medical field, you have to understand the scope of the problem.
Right.
At the time the study was published, we're looking at about 55 million deaths globally every single year.
It's a number that is almost impossible to visualize, 55 million.
It is. And out of those 55 million deaths, roughly 30% were attributed to cardiovascular diseases. That makes it the #1 killer on the planet by a significant margin.
And if we drill down even further into that specific statistic, about 40 to 50% of those cardiovascular deaths are likely due to acute myocardial infarction.
Which is the medical term for a heart attack.
Precisely. And specifically, we are talking about STEMI, ST segment elevation myocardial infarction.
Right, so we aren't just talking about mild chest pain or a warning sign here.
No, not at all. This is the classic catastrophic event. A coronary artery is completely blocked, 100% occluded, and the heart muscle downstream from that blockage begins to die almost immediately due to a lack of oxygen.
It is quite literally a race against time.
Time is muscle, as they say in the ER.
So the mission of this deep dive today is to explore how these researchers tried to find a better weapon for that race. The study focuses on a newer synthetic drug called Fondaparinux. The goal was to see if this new player could outperform or at least match the standard treatments of the time.
Which was primarily heparin.
Right. Could it match heparin without the heavy cost?
And when you say cost in this context, we definitely aren't talking about dollars and cents. We are talking about the physiological cost to the patient.
The bleeding.
Exactly. That's the main hook here. We have these standard treatments like unfractionated heparin, which we'll just call UFH for short, but they are notoriously difficult to monitor. They're messy.
Very messy.
And this study asks a very simple but profound question. Can a simple fixed-dose drug save more lives than the complex, messy treatments we were so used to using?
It really is the quest for simplicity in what is arguably a very complex, chaotic medical emergency.
So let's unpack this. Before we get into the nitty-gritty of the OASIS-6 trial methodology, we need to understand what the world looked like for a heart attack patient before this drug came along. What was the usual care? If I walk into an ER in 2005 clutching my chest, what was the status quo?
Well, assuming you were diagnosed with a STEMI right away, the clock starts ticking immediately. The medical community had an arsenal, but it was a highly imperfect one. Okay.
You would immediately get antiplatelet therapy, basically aspirin. That's to stop the platelets in your blood from sticking together and making the clot bigger. You might also get ACE inhibitors to help the heart remodel later on.
And then the big guns come out to actually open the blocked artery.
Right. You basically have two main paths to open that blocked pipe. Path 1 is thrombolytics. These are your clot busters. They're chemical agents you inject into the vein, they travel to the heart, and they chemically dissolve the blockage.
It's like pouring liquid Drano down the arteries.
In a crude manner of speaking, yes. It just breaks down the clot chemically. And then path 2 is mechanical, primary PCI, percutaneous coronary intervention.
Which most people know as angioplasty and stenting.
Exactly. This is where the cardiologist physically goes in with a catheter, usually starting through the femoral artery in the groin or the radial artery in the wrist. They thread it all the way up to the heart, open the artery with a tiny balloon, and then usually place a metal scaffold called a stent to keep it propped open.
Which sounds like the ultimate fix.
It is the gold standard, absolutely. But there is a major catch.
Access to the facility.
Exactly. Access. Not every hospital has a catheterization lab. In fact, globally, most do not.
Right. Building a cath lab and staffing it with interventional cardiologists 24/7 is incredibly expensive.
Highly expensive. So while PCI is a great tool, it's totally limited by geography and resources. If you have a massive heart attack in a rural area, you are likely getting the thrombolytic drugs, not the surgery.
So for a lot of people, especially in developing countries or rural areas, the chemical option, the drugs, that's the main line of defense.
Right. And that brings us to the blood thinners, the antithrombotics.
Yeah.
You need these to stop the clot from getting bigger and to prevent new clots from forming while the body tries to heal from the trauma of the heart attack.
And the standard for a long time was unfractionated heparin, UFH.
But as you mentioned earlier, UFH has some serious issues.
Right. Break that down for us. Why is UFH so problematic?
Well, first of all, UFH is a biological product. It's actually derived from animal tissues. Historically, it comes from pig intestines or cow lungs.
Wow.
Yeah. And because it is biological, its effect can vary wildly from person to person. It's not a uniform drug. It's essentially a soup of different molecule sizes.
So it's highly inconsistent.
Extremely. Because of that inconsistency, you can't just give someone a shot and walk away. You have to give a large bolus injection to start, then a continuous intravenous infusion.
Huh?
And then you have to constantly check the patient's blood clotting time, a test called the APTT, every few hours to make sure you are keeping them in the sweet spot.
The Goldilocks zone. Because if you give too little, the clot grows and they have another heart attack.
And if you give too much, the patient bleeds, sometimes fatally into the brain or the gut.
So it's an incredibly narrow therapeutic window.
It is. And historically, trials of UFH combined with aspirin and those clot-busting drugs didn't actually show a robust reduction in mortality.
Hey, really? So the standard of care wasn't even definitively saving more lives?
They thin the blood, sure, which is what you want. But the bleeding risks often canceled out the survival benefits.
That's the bleeding trade-off we mentioned. You're trying to save the heart muscle, but you might cause a massive internal bleed that kills the patient anyway.
Exactly. Now, there was another drug mentioned in the background of this paper, rivapirin. It was a low molecular weight heparin evaluated in the CREATE trial.
Did that one work better?
It did work. It reduced mortality. But it wasn't widely available. And crucially, it still significantly increased the risk of life-threatening bleeding.
So the medical community was basically stuck between a rock and a hard place. They desperately needed something effective but safer. And ideally, something easier to use than setting up an IV pump and drawing blood every 4 hours for heparin.
Right. Enter Fondaparinux.
Okay, so what exactly is this stuff?
Fondaparinux is a synthetic pentasaccharide.
Let's break that down for the listener. Synthetic means it's made in a lab, not extracted from pig intestines.
Correct. It is engineered from the ground up. This means it has incredible consistency. You know exactly what you are getting in every single molecule. There's no biological variation. And mechanism-wise, it is a factor XA inhibitor.
Factor XI. We hear about clotting factors a lot in medicine. Factor 8, factor 9. What makes factor XA so special in this context?
Think of the blood clotting cascade as a complex domino effect. One protein activates another, which activates another, until you get a solid clot. Factor XA is a very key domino situated near the end of the chain.
Okay.
Unfractionated heparin is like dropping a bomb on the domino table. It knocks over several different dominoes at once. It's a blunt instrument. Fondaparinux, on the other hand, is a sniper.
Oh, I like that analogy.
It selectively binds to antithrombin, which is the body's natural clot stopper, and accelerates its ability to inhibit only factor XA, nothing else.
So it's highly targeted. It doesn't mess with the rest of the coagulation system nearly as much as heparin does.
Exactly. And because it's synthetic and completely targeted, the dosing is much simpler.
Oh.
And it already had a track record before this trial.
Right, the OASIS 5 trial.
Yes. OASIS 5 looked at non-STEMI patients. So patients having heart attacks, but not the massive, completely blocked artery type.
Milder heart attacks.
Relatively speaking, yes. And that trial showed that Fondaparinux was just as good as enoxaparin. which is another type of heparin at preventing ischemic events, but with significantly less bleeding.
So Oasis 5 really set the stage. It proved the concept, and then Oasis 6 was the main event for the huge catastrophic heart attacks. Let's talk about how to design this study, because the scale of it is just, it's huge.
It is massive. 12,092 patients.
Over 12,000 people actively having a major heart attack enrolled in a clinical trial. That logistics of that are mind-boggling.
It really is an incredible feat of trial coordination. It involved 447 hospitals across 31 different countries. This is a truly global snapshot of cardiology, and it was a randomized double-blind trial.
Which is the absolute gold standard for scientific evidence.
Right.
Meaning neither the doctors treating the patients nor the patients themselves knew who was getting the new Fondaparinux and who was getting the placebo or the standard heparin.
Correct. But here's where the trial design gets really interesting and, frankly, slightly complicated to parse at first. They had to divide the trial into two separate groups, or strata. Stratum 1 and Stratum 2, and understanding the split is crucial for understanding the final results.
Okay, walk us through this. Why split the patients up at all? Why not just put them all in one big pool?
Because medical practices vary so much based on where you are and what the doctor thinks is best. In some cases, a doctor might feel that giving unfractionated heparin is absolutely medically indicated. For example, if they're about to roll the patient into a PCI to put in a stent, or if they're using a specific type of clot-busting drug that requires heparin alongside it.
Makes sense.
But in other cases, maybe in a small hospital without a cath lab or using a different thrombolytic, UFH might not be the standard of care, or the doctor might feel the bleeding risk is too high, so it's not indicated.
So Stratum 1 was for the patients where the treating physician decided UFH was not indicated.
Right. There were 5,658 patients in this specific group. They were randomized to receive either Fondaparinux or a placebo.
So essentially, it's the new drug versus nothing.
Well, drug versus placebo, but yes.
Yeah.
Standard background care plus either the new drug or a dummy shot. And then Stratum 2 was for patients where the doctor felt UFH definitely was indicated.
And how many were in that group?
There were 6,434 patients here. They got either Fondaparinux or the standard unfractionated heparin.
So Stratum 2 is new drug versus the old standard.
Exactly. This brilliant design allowed the researchers to test the drug in two very different real-world scenarios simultaneously without forcing doctors to practice outside their comfort zones.
That's a really elegant way to handle real-world clinical variations. And let's talk about that simplicity aspect again. The dosing regime for Fondaparinux just sounds almost too good to be true when you compare it to heparin.
It is remarkably simple. The dose was 2.5 milligrams, given once daily.
Just once a day.
Once a day, via subcutaneous injection. Meaning it's just a tiny needle right under the skin, much like a standard insulin shot. And crucially, no monitoring required.
No blood draws every 4 hours to check APTT clotting times.
None whatsoever. You give the shot, and you're done for the day.
Compare that to the control group in Stratum 2 getting the standard heparin.
Right. The control group getting UFH had to have a large bolus injection right up front. Then they had to be hooked up to a continuous IV infusion pump for 24 to 48 hours. And they required constant blood draws to monitor that APTT level to adjust the IV drip up or down.
It just sounds like a logistical nightmare for the nursing staff compared to a single pre-filled syringe.
It absolutely is labor-intensive. And remember, this is a double-blind trial. So to keep the study completely blind between a simple shot and a complex IV drip, they had to use a double dummy technique.
Double dummy. I love that term. Explain how that works in practice.
Okay, so imagine you're a patient in the trial. If you are randomized to the Fondaparinux group, you get the real subcutaneous shot of the drug. But you also get a fake IV bag of saline hooked up to you that looks exactly like a heparin drip.
Oh, wow.
And the nurses even do fake blood tests and make fake adjustments to the saline drip rate based on sham lab results, just to maintain the illusion.
That is wild. And the other way around.
If you are randomized to the standard heparin group, you get the real IV drip of heparin, the real blood tests, and the real adjustments. But you also get a fake subcutaneous shot every day that just contains saline instead of Fondaparinux.
That is serious dedication to the scientific method. They really went out of their way to make sure absolutely no one, not the doctor, the nurse, or the patient, could guess which treatment they were getting.
It is essential in a trial like this. Otherwise, subconscious bias creeps in. A doctor might treat a patient differently if they know they are on the experimental drug.
Okay, so the stage is fully set. We have over 12,000 people, half getting the super simple daily shot, half getting either standard messy care or a placebo. They ran this treatment phase for up to 8 days.
Yes.
What were the headline numbers? When they unblinded the data, what happened?
The primary outcome they were looking for was a composite metric. They were looking at death or reinfarction, meaning a second heart attack at the 30-day mark.
And the results. Did the simple shot win?
It did. In the overall control group, which combines the placebo patients and the UFH patients, there were 677 events of death or a second heart attack. That is an 11.2% event rate.
Okay, 11.2%.
In the Fondaparinux group, there were 585 events. That is a 9.7% rate,
So it dropped from 11.2 down to 9.7.
which translates mathematically to a hazard ratio of 0.86. In plain English, that is a 14% relative risk reduction in death or a second heart attack.
And was that statistically significant? Because sometimes a small absolute drop is just noise in the data.
Oh, it was highly significant. The p-value was 0.008. In medical research, anything under 0.05 is usually considered significant. So a 0.008 is a very robust, undeniable finding.
A 14% reduction in death or having your heart explode again just by switching to a simpler once-a-day drug, that is incredibly impressive. But I noticed something really interesting about the timing of this benefit when I was reading the source material.
Yes, the timing is a key point here. The benefit was seen very, very early.
Like almost immediately.
By day 9, there was already a clear, statistically significant separation between the two groups, an absolute risk reduction of 1.5% right out of the gate.
And that gap didn't close later on, did it? Like it wasn't just delaying a bad outcome by a few weeks.
No, the benefit persisted. They followed these patients out for 3 to 6 months, depending on when they enrolled, and that survival benefit was maintained all the way through. This wasn't just kicking the can down the road. It was a genuine, sustained improvement in survival.
Let's talk about the death part of that death and reinfarction composite score. Because sometimes these massive trials combine outcomes, and later you find out that the drug only prevented minor asymptomatic heart attacks, but didn't actually stop people from dying.
That is a critical distinction to make, and it's a common trick in lesser studies. But in OASIS 6, total mortality on its own was significantly reduced throughout the entire study.
Okay, that's huge.
And when the researchers look at the specific cause of death for the patients who didn't make it, the reduction in mortality was entirely driven by a reduction in cardiac deaths.
So fewer people dying from progressive heart failure or myocardial rupture or having another massive fatal attack.
Exactly. Non-cardiac deaths like dying from a car crash or an infection were exactly the same in both groups, which is exactly what you would expect to see. But the Fondaparinux specifically protected the heart from failing.
Now, we have to address the elephant in the room. We talked about it at the top of the show. With any blood thinner, there is the bleeding risk, the bleeding paradox. Usually, if you thin the blood aggressively enough to stop a heart attack, you pay a steep price with hemorrhages.
That is the paradox. The historical expectation is that a simpler, more potent, more targeted drug would equal more bleeding complications.
But that's not what happened here.
No, it wasn't. In OASIS 6, severe bleeding was not increased at all.
It wasn't increased even slightly.
Actually, there was a trend toward fewer severe bleeds in the Fondaparinux group compared to the control group.
Wait, really?
Yes, 61 severe bleeding cases in the Fondaparinux group versus 79 cases in the control group.
That is completely counterintuitive. You give a better blood thinner and they bleed less.
It gets even more interesting when you look at specific types of fatal complications. There was a statistically significant reduction in something called cardiac tamponade.
Okay, for you listening who maybe haven't been to medical school, what exactly is cardiac tamponade? Because it sounds absolutely terrifying.
It is truly terrifying. It's one of the most dire emergencies we see.
Oh.
The heart doesn't just hang loose in the chest. It sits enclosed in a tough, fibrous sac called the pericardium. Right. If the heart muscle tears, which is a very real risk when the tissue dies and turns mushy during a massive heart attack, blood leaks out of the heart and into that tightly sealed sac.
And the sac doesn't stretch.
Exactly. It fills up with fluid, and it literally squeezes the heart from the outside. So the heart can't expand to pump blood. The blood pressure drops to 0. It is usually fatal very quickly.
And Fondaparinux reduced the rate of this happening.
Significantly. There were only 28 cases of cardiac tamponade with the new drug versus 48 cases in the standard care group.
But why? If Fondaparinux is a blood thinner, shouldn't it make any leaking from the heart much worse? It should be harder to clot the tear.
You would certainly think so. But the leading theory from the researchers is that by preventing a second heart attack so effectively, the drug preserved much more of the actual heart muscle.
Ah, I see.
Right. If the muscle tissue doesn't die and become necrotic, it stays strong. It doesn't get weak and rupture in the first place. So you have far fewer ruptures occurring, which leads directly to fewer tamponades.
So the drug works so incredibly well at its primary job, saving the heart muscle from dying, that it actually prevented the mechanical failure of the heart tearing itself apart.
That is the interpretation of the data. And it's a very, very powerful finding.
There was also a really weird finding in Stratum 1. Remember, that's the group comparing Fondaparinux to a placebo, the patients who weren't indicated for heparin.
Yes, the drug versus nothing group.
You would absolutely expect the group getting the active blood thinner to bleed more than the group getting a saline placebo. But the data showed fewer bleeds with Fondaparinux even there. How is that biologically possible?
It's a genuine puzzle. The authors admit in the paper that it might just be the play of chance in the data, but they also speculate on a really fascinating biological mechanism.
Let's hear.
When you give someone thrombolytics, the intense clot-busting drugs, you break down the main clot, but you create a massive amount of what we call fibrin degradation products in the bloodstream.
These are basically the microscopic debris from the dissolved clot.
Exactly. It's clot debris. But these debris products aren't harmless. They can actually interfere with the body's natural clotting ability elsewhere and cause systemic bleeding.
Oh, wow.
It is entirely possible that Fondaparinux, by selectively inhibiting the clotting cascade way upstream at factor ZAG, somehow counteracts or stabilizes this chaotic bleeding response caused by the clotbuster debris.
So it brings order to the chaos in the bloodstream.
In a way, yes, it's speculative, but it is a fascinating physiological hypothesis.
So far, this sounds like an absolute miracle drug. It's simpler to give, it's safer, it saves more lives, it prevents the heart from rupturing. But there is always a but in medical science. Section 5 of our outline today calls this the plot twist.
And it is a very significant plot twist.
Yeah.
The drug worked beautifully for almost everyone in the trial, except for one highly specific group.
The patients undergoing primary PCI, the ones getting stents.
Correct. The patients who bypassed the clot-busting drugs and were rushed straight to the cath lab to get a balloon or stent placed mechanically. In this specific subgroup, Fondaparinux showed absolutely no benefit compared to the old standard UFH.
In fact, the hazard ratio was 1.24, right? Meaning it was actually trending towards worse outcomes for these patients.
Yes, it was trending worse, though it didn't quite reach statistical significance for harm, but it clearly wasn't helping them.
What went wrong? Did the drug just stop working when they put a stent in?
It wasn't that the drug failed to protect the heart tissue systemically. The issue turned out to be entirely mechanical. They saw a much higher rate of something called guiding catheter thrombosis.
That means actual blood clots forming on the surgical equipment itself.
Yes. The catheters used in PCI are long, hollow plastic tubes. It turns out that Fondaparinux is fantastic at thinning the blood circulating in the body, but it is not sticky enough to coat the plastic of the catheter wall and prevent clots from forming right on the tip of the tool while it's inside the artery.
Oh, wow. So you have essentially 0 cases of this catheter clotting with regular messy heparin, but you had 22 cases of it with Fondaparinux.
Exactly. Unfractionated heparin is a messy biological soup. But that actually works to its advantage here because it coats everything, including foreign plastic tubes, very well. Fondaparinux is just too precise. It left the catheter completely unprotected.
And a clot forming on the tool you were using to clear a clot is bad news.
Very bad news. This led to more coronary complications actually during the stenting procedure. Things like abrupt closure of the artery they just opened, or the no reflow phenomenon, where the artery is technically open but blood still won't move to the microvessels. The complication rate was 270 in the Fondaparinux group versus 225 in the control group.
Honestly, this sounds like a complete deal breaker for using this drug in PCI patients. If I'm a cardiologist, I don't want my tools clotting up.
It absolutely would be a deal breaker if they hadn't found the solution hidden within their own trial data.
Which was what? How did they fix it?
Well, the trial protocol allowed doctors to give a dose of standard unfractionated heparin, actually during the PCI procedure, if they felt they needed to, kind of as a rescue therapy.
Okay.
When the researchers look back at the subset of patients who got their daily Fondaparinux shot, but then also got a standard shot of regular heparin just for the duration of the procedure, the catheter complications completely disappeared.
Oh, really? So you just need the best of both worlds.
Precisely. You use Fondaparinux for the baseline systemic protection, keeping the patient safe in the ward day to day without bleeding. But for the 45 minutes they're actually lying on the table with plastic tubes threaded into their arteries, you give them a little bump of standard UFH just to keep the equipment clean.
That seems like a very manageable workaround.
It is. It immediately became the standard clinical recommendation based on this trial. Do not use Fondaparinux alone for primary PCI. Just add UFH on top for the procedure itself.
Okay, so that perfectly explains the PCI group anomaly. Let's look at the other major subgroups because this is where the drug really shined in the data.
Yes, the thrombolytic group. This is a huge win. These are the patients receiving clot-busting drugs. For them, Fondaparinux significantly reduced death and reinfarction with a hazard ratio of 0.79. That's a 21% reduction.
And since streptokinase was the most common clot buster used in this study, I think it was about 73% of the thrombolysis patients. That is a massive impact for hospitals that rely heavily on chemical drugs rather than surgery.
Correct. Streptokinase is cheap and widely available globally, making it 21% safer and more effective just by pairing it with a simple shot is a game changer. And then there is the no reperfusion group.
Right. Our outline refers to these as the highest risk, most neglected patients. Who exactly falls into this category?
These are the tragic cases. Patients who arrive at the hospital way too late for clot busters to do any good, or they have severe contraindications, maybe a history of bleeding strokes, so you can't give them thrombolytics, or they're simply in a facility with absolutely no resources to clear the blockage, mechanically or chemically.
And that's a lot of people globally.
About 24% of the entire study population ended up getting absolutely no reperfusion therapy, no stents, no clot busters, just basic medical management.
And how did Fondaparinux perform for them?
It reduced their risk of death or a second heart attack by 20%, a hazard ratio of 0.80.
That is incredible. These are people with basically no other life-saving options on the table, and this simple once-a-day injection cut their risk by a fifth.
It is a major public health win. It unequivocally shows that even if you can't physically open the blocked artery, stabilizing the body's clotting system with Fondaparinux saves lives all on its own.
And what about the overall risk profiles? The study mentions using the GRACE score to stratify patients.
The GRACE score is basically a validated clinical tool. It's a way of calculating statistically how likely a specific patient is to die based on their age, heart rate, blood pressure, and lab values.
Okay.
The study found that Fondaparinux worked the absolute best in the highest risk patients, those admitted with a GRACE score over 112.
Can we put a hard number on that clinical benefit for the listener?
Yes. For every 1,000 high-risk patients treated with Fondaparinux instead of standard care, the drug outright prevented 34 deaths or reinfarctions.
34 lives saved or major events stopped per 1,000.
That is a very, very high yield for a single medical intervention.
So if we zoom out to the broader global health implications, section 7 of our deep dive today, the simplicity factor we keep coming back to, it's not just about convenience for the tired ER nurse, is it?
Not at all. It is fundamentally about access and healthcare equity.
Right.
Think about a small district hospital in a developing nation or even a rural urgent care clinic in a developed country. They might not have enough automated infusion pumps to run continuous heparin drips on multiple patients.
Right.
They almost certainly don't have a 247 lab that can run APTT clotting tests every 4 hours and return the results instantly.
UFH just requires a massive amount of hidden infrastructure to use safely.
It absolutely does. Fondaparinux requires a
sorry.
syringe. It's a fixed dose.
Yeah.
2.5 milligrams for everyone. No weight-based adjustments. No constant blood monitoring.
You could literally train a paramedic or a basic healthcare worker to administer it safely in minutes.
Exactly. It democratizes high-quality, gold standard heart attack care. Whether you are lying in a bed at a top-tier academic medical center in New York or a rural health outpost in sub-Saharan Africa, you can be given the exact same world-class antithrombotic therapy.
And the cost-benefit analysis of all this. The paper talks about net clinical benefit.
Net clinical benefit is a vital concept. It combines death, recurrent MI, and severe bleeding all into one single metric. Because think about it. If a drug miraculously saves a life from a heart attack but causes a severely disabling hemorrhagic stroke in the brain, is that really a net benefit to the patient?
Right, you haven't really helped them. You've just traded one catastrophe for another.
Exactly. But for Fondaparinux, the net clinical benefit was vastly superior to standard care at day 9, at day 30, and at the end of the study. The overall risk-benefit balance heavily favors the new drug, especially for anyone not going straight into a primary PCI.
Let's synthesize everything we've covered. We have gone through the biological mechanism of factor ZAG, the massive 12,000-person trial design, the impressive mortality results, the bleeding paradoxes, and the mechanical fix for the PCI patients. What is the final verdict here?
The final verdict from OASIS 6 is that for STEMI patients, the major heart attacks Fondaparinux is a massive advance in care. It significantly reduces mortality and reinfarction. It's provably safer than we expected, with fewer severe bleeds and fewer cardiac tamponades, and it's infinitely easier to deploy than unfractionated heparin.
With the one glaring caveat.
The PCI caveat. You cannot use it alone for the procedure itself. You absolutely must add UFH during the procedure to stop the catheters from clotting. But, and this is the key takeaway for clinicians, if you start a patient on Fondaparinux in the ER right when they roll in, and then 2 hours later decide to take them to the cath lab for a PCI, it's perfectly safe to do so, provided you just add the UFH while they're on the table.
So giving them that first simple shot doesn't burn your bridges. You can start the therapy immediately to protect them and figure out the surgical plan later.
Exactly right. And when you combine the findings of this study with the OASIS 5 results for the milder non-STEMI patients we talked about earlier, we really start to see a much bigger picture emerge in cardiology.
Which is?
Fondaparinux becomes this incredibly versatile, universally safe, foundational option for the entire broad spectrum of acute coronary syndromes. Whether a patient is having a massive STEMI or a smaller rumbling threat, this one drug, at one single fixed dose, covers the bases effectively and safely.
It vastly simplifies the decision tree for the emergency room doctor who is under pressure. It boils down to, is the patient having a heart attack? Yes, give the 2.5 milligram Fondaparinux shot.
Essentially, yes. It removes layers of complexity, and in emergency medicine, reducing complexity inherently reduces human error, and reducing error saves lives.
It's a truly fascinating journey looking back at the source material from 2006. We started the discussion with 55 million global deaths and ended with a 2.5 milligram pre-filled solution.
It really is medical science operating at its very best. Rigorous, massive-scale testing leading directly to practical, highly scalable, real-world solutions.
So we have thoroughly covered the study, the statistical implications, and the clinical nuances. But as we close out this deep dive, I have a provocative final thought for you, the listener, to mull over.
Go on, let's hear it.
If this drug is truly so simple to administer, no blood monitoring, fixed dose, just a quick subcutaneous injection, and if the survival benefit starts accumulating so early, does this pave the way for true pre-hospital treatment?
Oh, that is a very intriguing question.
Right. Could paramedics administer this in the back of the ambulance? Or even better, could it be kept in the patient's home for high-risk individuals to self-administer before the transport even arrives? The study itself actually mentions pre-hospital settings as a possibility in the discussion section. If time is muscle, and this drug is this safe and this easy to use, why on earth are we waiting for the hospital doors?
It definitely challenges the traditional logistics of emergency medicine, but the data from OASIS 6 certainly supports exploring that exact frontier. It's the logical next step.
Something to think about as the field continues to evolve. Thank you for watching The Funnel Effect.